Hey everybody, this is Kathy. Welcome back for another weekly live stream with Synapse Care Solutions. I know I'm in a little bit of a different place. I'm visiting my mom in California, so I'm sitting on her back porch getting things ready for you today. Anyways, I just wanted to welcome you back to week 2 of our very special social and emotional caring series here on our YouTube channel. And this month, we're going to be showcasing all different ways that we can expand the ways that we care. This week is a really special presentation that we did back in May of 2021. It was after the George Floyd incident, and we were having really important conversations around race and disparities. And I really am hopeful that those conversations that we talked about back then are still continuing today. So I really am grateful that you are here for yet another live stream. And this week, we have the privilege of having Dr. Rachelle Sey as our keynote presenter, and she was joined with Dr. Natalie Hunt, a nurse practitioner from Baltimore, who they're both speaking about ways that they are making differences in their unit to assess, identify, and address racial disparities, either in their personal practice or at the unit level and even organizational levels. So with that, we'll let the live stream from May of 2021 begin now.
Right. Looks like we're live. There they are. Oh my, so good to have you all here. Good morning. Good morning. We have an exciting topic, and I know everybody has a busy morning. So we'll go ahead and we'll introduce Rachelle. We'll let anybody else join as they come. But as many of you know, Rachelle is the clinical nurse specialist at Sharp Mary Birch, and she's been recently digging into this conversation since the California Association of Neonatologists meeting in March. And I think we all have a really strong interest in what can we do to recognize, acknowledge, and then take personal accountability for the part we play in some of these disparities. And how do we move forward from where we are? And we also are going to have a fellow planning committee member joining us. Her name is Natalie Hunt, and she'll be coming in later. She's actually on service this morning, but she's going to help with some of the Q&A at the end, and has been a really passionate advocate for similar things in her unit. Thanks, Rachelle, for taking time. Dr. Sey, as many of you maybe know, she just recently finished her PhD, and we're super proud of her and grateful for all the work she's doing on the planning committee and the support of the One Conference. Anyways, take it away, Rachelle, and thanks for being with us.
Yeah, thanks for having me to talk about how we all can improve racial disparities in our NICUs. I am in no way an expert on this topic, but I've just been doing a lot of sensing and looking to my own awareness in this topic. And I was fortunate enough to take a seminar course in my PhD doctoral work last semester on health disparities and health equity in research. And it was really eye-opening to me. And I hope that I can share some of that with you today within the perspective of how we care for our NICU patients and their families. So overall, the goal is to raise our awareness and foster open, safe dialogue within our NICUs around these sensitive topics. And today I hope to at least help define health equity and health disparities, as well as describe the presence of racial and health disparities in our NICUs and identify where these occur in the perinatal and neonatal context. And I also hope that we can identify at least 2 strategies that are aimed at reducing health disparities in the NICU. So looking for that 1 or 2 tangible things that we can start doing tomorrow that will help to start addressing our health disparities in the NICU. So I'm going to start with a little bit of background. Some of this you may be aware of, some of this may be new information for those of you listening, but nearly 700 women die each year in the US as a result of pregnancy or pregnancy-related complications. And American Indian and Alaskan Native and Black women are 2 to 3 times as likely to die from a pregnancy-related cause when compared to white women. And we also know that preterm birth continues to rise in the US, and in 2017, there were nearly 1 in 10 infants who were born less than 37 weeks in the United States. And infants born to minority women or women of color represent a disproportionate percentage of these preterm births. And the preterm birth rate, according to the March of Dimes report that was just published, showed that rates among non-Hispanic Black women were 50% higher than rates among all other women. And this is a graph from that March of Dimes report that was just published. And it shows you that when we look at preterm birth rates by race and ethnicity, and this is looking at aggregates from 2016 to 2018, the rate among Black women for preterm births was 13.8%. And when that was compared to all other races and ethnicities, it was 50% higher. And then looking specifically at California, and for those of you that may be in other states, you can go to the March of Dimes report card and look at this for your own states. But within the state of California, you can see that the preterm birth rate among Black women was 43% higher than the rate among other women, with a total disparities ratio of 1.31. And we're looking for a lower disparity ratio, which is better. So when there's a ratio of 1, it indicates that there's no disparity. And what they showed with California is that our change from baseline actually worsened and it increased. And so the percentage of preterm births in California among Black mothers was 12%, compared to American Indians, who were also higher at 11.3%, and white mothers with preterm births was at 7.7%. So Black infants also experience a higher incidence of infant mortality, and the mortality rate for Hispanic Black infants was 10.8%, while the mortality for non-Hispanic white infants was 4.6%, and that also is from the March of Dimes report. And you can see here the overall infant mortality rate in the US was 5.7%. And you can see there has been a slight decrease in that trend from 2008 to 2018. But when you look at this infant mortality rate by race and ethnicity, you can see there the Black rate is 10.8, and the Asian mothers infants have the smallest percentage or rate at 3.6. And again, looking specifically at California, you can see that the preterm birth rate started to decrease and then has been starting to rise again as we look going towards 2019. And the overall infant mortality rate in California is at 4.2%, and there has been a slight downward trend in the infant mortality rate. We'll talk a little bit more about social determinants of health in a little bit, but social determinants of health, particularly factors to consider, are access to education, employment, and housing, can lead to our increase in poverty levels. And poverty levels are a key determinant of poorer physical and mental health outcomes for both women and infants. And it's really important for those of us caring for these populations to really understand how that affects our care that we provide. Poverty has also been shown to be a key contributor to preterm birth, low birth weight, and congenital anomalies. It's important to also understand that disparities do exist in health outcomes for all women and infants, but the highest burden does fall on our African American women and infants. African American pregnant women are 2 times more likely to experience preterm birth and 3 times more likely to give birth to a low birth weight infant. And this disparity persists even after controlling for factors or social determinants of health, such as low income, low education, alcohol, and tobacco use. And to explain these persistent differences, researchers are now really looking at toxic stress and how environmental stressors related to racism can serve as a source of this chronic stress and negatively affecting the body's hormone levels, which can increase the likelihood of preterm birth and delivery of low birth weights. This is an overall picture across the United States of race and ethnicity disparity by states. And you can see the levels of overall disparity from the highest to the lowest. So the states with the highest level of disparity are those that are the darkest purple. So California, Montana, Alaska, North Dakota, Louisiana. And then you can see some of the states that actually have the lower levels of disparity by state. So that's a little bit of the background, and I just want to touch on a few key definitions before we move on, looking specifically at defining what is health equity and what is health disparities. So health equity is achieved when every person has the opportunity to attain his or her fullest health potential, and not one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. So really, health equity means that we're equalizing the conditions for health across all groups, especially those that are marginalized and disadvantaged. And many of you have probably seen either this graphic by Robert Wood Johnson Foundation or similar graphics where you compare what is equality and what is equity. And you can see in the top picture, each individual was provided the same bicycle, and it doesn't fit all of them. For some, it's too large, for some, it's too big, and for some, they can't even use the bike. But when you look at equity, you provide an individualized approach to help each person reach their own health potential. And so you provide something that fits specific to those individuals. So really, in order to build a culture of health, we have to ensure that everyone has the basics to be healthy. And when it comes to expanding opportunities for health, thinking the same approach will work universally is like expecting everybody to be able to ride the same bike. So there's different things that we have to take into consideration when we think about equity: health literacy, language preferences, access to healthcare, transportation, and even access to basic resources such as food, clean water, and other resources after these patients are discharged or while they're in our care in the hospital. We just need to continue to remember that one size does not fit all. So moving on to health disparities. So when health equity is not achieved, we end up with health disparities. And health disparities are really the differences in health outcomes that are explained by social, economic, and environmental disadvantages. These differences exist among distinct segments of the population. And the majority of health disparities often result from social determinants of health. And some of those include race, ethnicity, sexual identity, disability, socioeconomic status, and even down to geographic location. Many of these things are multifactorial and represent the differences that we see in health outcomes. So according to this author, Braveman, he identified 6 key principles of health disparities. In particular, all people should be valued equally. Health is an important value for workforce participation and participation in our democratic process, so expecting healthy individuals. And then there should be an expectation that there's non-discrimination by religion, language, gender, sexual orientation, age, physical and mental abilities, socioeconomic status, geography, or political affiliation. And each individual should have the right to health and a standard of living that's adequate for their health attainment. And then social determinants of health should also equally be distributed. And health differences adversely affecting the socially disadvantaged are particularly unacceptable. I think it's important to also point out that we may see disparities among outcomes, but health disparities doesn't refer generically to all health differences or even to health differences warranting our focused attention. But when we're talking about health disparities, we're talking really about a specific subset of health differences of particular relevance to social justice, because they may arise from intentional or unintentional discrimination or marginalization. And in any case, they are likely to reinforce social disadvantages and vulnerability. Therefore, when we look at health disparities and really overall health equity is really a social justice in health. So according to the Healthy People 2030, social determinants of health really encompass these 5 key areas: access to healthcare and quality healthcare, education access and the quality of that education, social and community context, our economic stability, and the neighborhood and built environments in which we live. Social determinants of health, as I mentioned, really significantly impact health disparities and health equity. And these are conditions that affect, each of these 5 conditions really affect us where we are born, grow, live, work, and age. and they are influenced generally by policy and distribution of money, power, and resources at a global, national, and local level. And I think if all of us really think about it, we can come up with something we've seen in the media, something we've seen even in our own healthcare settings, where we see this disparity surface. Also, the Healthy People 2030, they're really taking a specific focus on these 5 areas of social determinants of health because they really feel that these are key to achieving health equity. And they're really taking an innovative approach with these 2030 goals and looking at social determinants of health and really highlighting the importance of upstream factors. Generally, they're not related to healthcare delivery, but they are important in improving health and reducing disparities. I came across this blog and this image in the blog where they really turned the Maslow's hierarchy of needs into Maslow's hierarchy of inequity, where at the bottom of the pyramid, we know that we need to achieve physiologic stability, and we move up the pyramid in order to achieve self-actualization and realizing our personal potential, self-fulfillment, and personal growth. But as this pyramid of inequity demonstrates, in the United States, communities of color often can face a steeper climb to fulfill these basic needs. I think many of us probably don't relate necessarily to some of achieving these physiologic stability. A lot of us aren't saying, I wish I had a home, or is it okay to sleep here? When will I get my next paycheck? Is this water safe to drink? And that really just demonstrates that those things do exist. And the level of physiologic stability in this pyramid is really where a lot of the inequity currently exists. And until individuals can meet that physiologic stability, they really can't move up this pyramid. And so for particularly individuals of color and communities of color, they have a steeper climb to get to the top of this pyramid. And then I also just wanted to share a few articles that have been published specific to racial and ethnic disparities within the NICU. And this first article by Sigurdsson and colleagues, which was published in 2019, identified that racial and ethnic disparities in health outcomes of newborns requiring care in the NICU have been reported, but the contribution of the NICU care, or particularly the quality of NICU care and how that relates to disparities in outcomes, was unclear. So they completed a systematic review where they ended up looking at 44 articles. All these articles referenced disparities in one way or another. And overall, this study revealed that there were complex racial and ethnic disparities across structure, process, and outcome measures, and most often disadvantaging infants of color, especially African American infants. Just for example, some of the articles that they reviewed in the systematic review relating to structure, they found that staffing ratios, or even looking at where an infant was delivered, was it the appropriate setting or the appropriate level of care for that infant to be delivered. They also looked at just overall composite quality scores and found that there were disparities among each of those. And when looking at process measures, they also found disparities reported in some of the articles they reviewed, specifically related to breast milk and breast milk feedings. They found disparities. They also found disparities in high-risk follow-up referrals and attendance at high-risk infant follow-up clinics. They also found disparities reported in articles with access to the first skin-to-skin, even just parent satisfaction. And then in overall outcomes, they found disparities across intraventricular hemorrhage, NEC, ROP, and chronic lung disease. This was another article that looked at the Vermont-Oxford Network NICUs, and this article really was looking at the racial and ethnic minorities who potentially receive lower quality health care than white and non-Hispanic individuals in the United States. And they sought to understand where these infants are receiving care and what that quality of care looks like across those NICUs. And what they found in this article is that Black, Hispanic, and Asian infants were often segregated across NICUs, which reflected the general racial segregation of minority populations within the US. And they also found that there were large differences in geographic regions within NICU quality. And particularly what they found is that Asian infants received care in the highest quality NICUs, while Black infants received care generally in the lowest quality NICUs. So they did identify that there was racial segregation and inequality across where these infants were receiving care and the quality of that care they received. This was another article that was looking at infants specific to the state of California. And in this prospective observational analysis, they reviewed over 18,000 very low birth weight infants within 134 California NICUs. And they used this objective baby monitor tool that's used within the CPQCC reporting metric. And this is a composite indicator that looked at 9 process and quality measures and then was risk adjusted for each NICU in order to standardize across the population for comparison purposes. And in this article, they also found that there was significant racial and ethnic variation in the quality of care, both within NICUs and between NICUs. And the overall findings of this study did show that these large racial and ethnic differences of quality did exist. And they also found that the quality deficit among disadvantaged populations was actually concentrated within modifiable measures of quality. In particular, they found that white infants generally appeared to score higher on measures of processes considered to indicate higher quality of care. And these are processes that should generally be standardized within our NICUs, and we shouldn't see any differences by race or really any disparities at all. And some of those process measures included administration of antenatal steroids, rates of hypothermia on admission, the timing of the first eye exam, and they also found disparities among healthcare associated infections and whether the infants received any breast milk at discharge. So within the literature and the data that we have available, there has been disparities demonstrated within NICU quality outcomes related to neonatal mortality, morbidities including admission hypothermia, IVH, ROP, late onset infection, NEC. There's also been disparities reported in breastfeeding rates, the amount of breast milk at discharge, and the use of breast milk post-discharge. Disparities have also been demonstrated with end-of-life decision-making and discharge preparedness and transition to home from the NICU. This was another interesting article that looked at disparities in NICU quality of care by taking a qualitative approach and taking narrative accounts from both family and clinicians. And in this qualitative analysis, they ended up looking at 324 narrative accounts that were submitted across healthcare providers and parents. And the sample included nurses, physicians, nurse practitioners, as well as family advocates. And they found that language barriers was a large parental factor that was present in about 47% of the narrative accounts that they received. But they also found that there were other parent factors, including culture and ethnicity, race, socioeconomic status of the parents, whether there was drug use, immigration status, gender, and disability. And all of those were items that came from the narratives. And then when they looked at the overall themes that came from those narratives, they saw 3 themes that emerged in the types of disparate care from those narratives, including neglectful care, judgmental care, and systemic barriers. So when looking at neglectful care, this was described as families not necessarily being updated or educated as often or as thoroughly as others. And so staff's a portion of care such that certain families would receive less time or attention and appear to be ignored or avoided. But some of this was related to language barriers or not being able to speak the same language of the families. And then when they looked at the theme around judgmental care, this was where staff evaluate the family's moral status based on factors such as race, class, or immigration status. So this is really where stigma presented itself in judging, and where biased attitudes towards families and circumstances surfaced. And then systemic barriers, these were where there might have been disparities in visitation, or staff were unable or unwilling to help address some of the barriers that families faced that were specific to visitation. And then those all led to potentially suboptimal care when they looked at those types of disparate care. So now I want to look at how we can develop an action plan to address these disparities that we've discussed. And I think the first thing we all need to do is really just to increase awareness, both for ourselves and for those that we work with. And just sharing some of the disparities that do exist, I think will help all of us to increase that awareness. And then we each need to work on reflecting on our own implicit biases, followed by reflecting on existing narratives and languages that are already existing in our NICUs, and then identify gaps and opportunities within our own NICUs, and then engaging in active listening and open dialogue. So starting with implicit bias, this is the unconscious or hidden bias that we don't really know exists within each of us. It's generally negative associations that we unknowingly hold. And generally, it's expressed automatically and without our conscious awareness. And sometimes these implicit biases tend to undermine our implied or stated commitments to equality, and then are revealed without us even realizing it. And I'm guilty of this myself, but just really saying, I treat everybody the same. And when I really look at my own implicit bias, and I really start to self-reflect on that, I do notice that I hold some biases that I might not have known were there. And so I think it's really important for all of us to work on that own self-reflection. And in order to reflect on our own biases, we really need to think about our own beliefs and how our own internal biases are unconscious and require significant and potentially difficult self-reflection to uncover. We also need to be open to feedback and observation from others, because others may see these things that we don't see in ourselves. And then we also need to consider how these biases may reflect in the care that we provide to our patients and families. And I think we've all heard of cultural competence, but it's really important to look at the different layers of cultural competence. And the first layer that we typically think of is cultural awareness, and identifying our own self-awareness and bridging our own skills and identifying who am I. And then the next level, and taking that to the next stage, is cultural knowledge, and how are my beliefs and who I am reflected or different from others, and what other knowledge do I need to know in order to uncover that. And then finally, the last stage of cultural competence is cultural sensitivity, and taking into consideration these cultural differences that we identified and respecting those differences, and asking the question, am I open to respecting others' differences? And can I avoid the judgment to others' differences? But we can't really stop here. We need to all be an advocate and a voice for change. This is a graphic that was published in a recent article in Advances for Neonatal Nurses, and it's from an article called Becoming an Anti-Racist Neonatal Community. And I really think that this is a nice graphic for us each to do our own reflection on where we are in each of these zones, from fear zone to learning zone to growth zone, and becoming an anti-racist, and how we advocate and how we provide care to our patients and families. You can see here in the fear zone, it's where you avoid asking hard questions, you deny that racism or disparities are a problem, and you strive just to sit in your own comfortable zone. Whereas moving into the learning zone, you can understand how you understand your own privilege in ignoring racism. You're starting to educate yourself about race and structural racism and how that perpetuates these disparities that we see. And you seek out questions that might make you uncomfortable in order to seek this awareness. And then the final zone is the growth zone, where you're able to sit with your own discomfort. You can educate your peers on racism and disparities and how that harms our profession. And this article allows you to reflect on where your own biases are or where you sit within each of these zones. But then the article also provides actionable steps that we can take to move ourselves from one zone to the next zone. And then these are generally some nice reflection questions that you can take some time to sit on and think about when you're uncovering your own implicit bias and creating your own personal commitment to that. But how does your experience with race and racism impact you? And what are some areas in your units that you see bias affecting the care and outcomes? And what concepts and actions will you take to impact health equity in your unit? And then I've also added a few tools here. I'm not sure if any of you have heard of or taken yourself the implicit bias tool or test at Harvard, and I have the link there, or you can simply just Google implicit bias test Harvard, and this will pop up. But this Project Implicit is really a nonprofit organization that was founded in 1998, and they have a series of implicit bias tests available at this site that you can take, and they're related to race, ethnicity, religion, skin tone. And I found that taking these tests was very eye-opening in helping me to uncover some of my own biases that I didn't know existed. So I encourage you to go and take some of those tests and just see where you sit with some of those responses. And then another available tool that you can find just by Googling it is this Quick Discrimination Index. And this is a 30-item self-assessment, and it assesses your sensitivity, awareness, and receptivity to cultural diversity and gender equity. And it's designed to assess our subtle racial and gender biases. So it's a self-assessment inventory. So if we each take it and we're honest in our answers, it can help us to become more aware of our attitudes and beliefs pertaining to these racial and gender bias issues. The next step is really reflecting on the existing language and narratives that we hold ourselves, but also that we see within our NICUs and our organizations. So really looking deep to find where do racial stereotypes show up in our shared language, and how is that reinforced within ourselves, our team, and our organizations. And really looking at examining our publications, what's on our website content, social media content, and even internal policy documents related to visitation or other items, and looking specifically at words and images that might reinforce stereotypes, or looking at language that trivializes the experience of patients and families, especially those of color, and looking for messages that reinforce a white dominant culture or norms. And one of the examples that I have here is we were working on a parent guidebook for our NICU and a parent education resource. And when I worked with marketing, they supplied the pictures in this beautiful color magazine or parent guide for our NICU families. And when I brought it to our unit practice council to review, it hadn't even dawned on me, but the very first thing that they noticed is that all of the images that were in the guidebook were not reflective of the patient demographic that we cared for. Each of the images were of white families or white infants. And so we went back to marketing and we asked for them to provide more diversity in the images, just to really reflect more of the demographic of the patient population we take care of. But some of those are really the unconsciousness of when we're looking at something that we don't even pick up on those things. So really having multiple people look at that and provide feedback really helped us to uncover that. And then also within these shared languages or narratives is the topic of stigma. And stigma is really giving someone an undesirable label that's based on negative social perceptions. And stigma keeps these individuals from reaching their fullest health potential. It can be an undesirable label that we give an individual or an entire group. And it can be related to race and ethnicity or a variety of different things, such as a mother that's been doing drugs or a homeless patient. And it's when we look at health-related stigma, it's this social process or personal experience that's related to a health condition, and it could be characterized by the perception of exclusion, rejection, and blame, and it contributes to the psychological, physical, and social morbidity of patients. And stigma can occur really across many levels, both individually, interpersonally, institutionally, in our communities, or within specific public policies. So some individuals may experience stigma really on multiple levels. And the effects of stigma are really profound. And stigma leads to feelings of shame and unworthiness in these individuals when we assign labels that ultimately can result in social isolation, poor quality of life, potentially less access to healthcare because of their shame or isolation, delayed diagnoses, or illness and death. And many times individuals don't even realize that they're portraying stigma on a certain group or individual, and they don't even understand that their words and actions could be stigmatizing. So the March of Dimes has this website, Beyond Labels, and they have a whole page dedicated to stigma and reducing stigma and care of women and infants. And this is a little video clip that you can find at that website. Words are things, they get on walls, they get in your wallpaper, they get in your rugs, in your upholstery, and your clothes, and finally in you. And the impact of how stigma really affects these women and their infants. So I encourage you to go and take a look at that website as well. So here are some additional questions on how we can reflect on existing language and narratives. How can we each use our own language to model for our NICU team and the other people that we work for? How can we address stigma and think of some of the stigma that we see in our own units and language that we hear ourselves or others say, and how can we develop a counter narrative so that we can help to uncover that stigma and address that stigma so that it doesn't keep continuing to perpetuate? And then what are our own specific health equity goals, including short and long term? And how do these individual goals fit into the larger narrative of health equity for our patients and families? The next step then is to track and trend and to identify gaps and opportunities. Because particularly in that article that was published by Jochen Profit and his colleagues, he found that a lot of the disparities within NICUs were potentially related to processes or things that we have control over that are potentially modifiable. Therefore, really looking at race and ethnicity and some of the disparities we see in our NICUs lend itself well to using QI methodology and how we address these. And so we can identify gaps in our own NICU outcomes disparities. And for those of us in the state of California, we report our outcomes to CPQCC database. And within that database, they've created a health equity dashboard specific to each NICU. So you can go in and actually look at your own outcome data or outcome morbidities within your own NICU and look at that stratified by race and ethnicity to see if you do have disparities in your outcomes based on race and ethnicity. And I think that's a really good place to start to look at where we can focus some extra attention. And then all of us are working on various quality improvement projects within our NICUs, whether it's trying to achieve earlier skin to skin, improving breastfeeding rates. And really, we can identify for every quality improvement project that we're working on, creating an equity metric for that quality improvement project. And we can think about equity metrics both for the processes as well as the outcome measures. And a couple of examples for this within our own NICU at Sharp, we're doing a QI project on achieving earlier skin to skin in our LGAN infants that are less than 28 weeks. And we have made some significant improvements in that, where our baseline was 14 days before, on average, before babies were held the first time skin to skin. And we've been able to reduce that to 7 days, or just slightly above 7 days, with our goal being less than 7 days. But what we did is we decided to also take that average day from birth to first skin to skin hold and stratify it by language. So whether they were English speaking primarily or other language, and also stratify that by race and ethnicity. And what we found is there was a big difference between those patients that spoke English were held a lot sooner for their first skin to skin compared to those that spoke Spanish. And then we also saw, when looking at race and ethnicity disparity stratification, we didn't really see a lot of difference across all race and ethnicities, but when we separated out Hispanic from all other race and ethnicities, we did see a significant difference, where the baseline for our Hispanic families was average day of life was 23 before the first skin to skin, compared to the 14 days or 11 days of the other families, race by race and ethnicity. And we have shown now over time from our baseline that we've been able to decrease that disparity. Finally, we need to advocate and engage in active listening and open dialogue. And I stole this first bullet point, or borrowed it, I should say, from my kids' school. They're in a Leader in Me school, and they focus on the 7 habits of highly effective people. But they've added this 8th habit at their school, which is to find your inner voice and help others to find theirs. And I think if all of us strive to do that, and find our own awareness, look at our own implicit biases, and help others to find theirs, it'll be a good place for us to start in moving forward in minimizing these disparities. And then we also need to work on creating safe, open spaces to raise awareness, dialogue, and collaborate. And we also need to be open to our own feedback and self-reflection. And I think it's really important that we also need to understand that there are differing perspectives of our own, and to be open to learning from those differing perspectives. And inside each of us, we also need to be consistent in the messages that we're sharing and building relationships among our other teams. And maybe there's other units within your hospital that are working on similar goals to reduce disparities, and coming together and working on those initiatives collaboratively. And then using various forms or avenues for communication to highlight the disparities or the projects that we're working on to minimize these disparities. So whether it's unit staff meetings, newsletters, or other communications that you use in your units. And then I just, as we wrap up, really wanted to share some additional resources that you can look at your own leisure. But the National Association of Neonatal Nurses has a whole page devoted to racial disparities in the NICU. And they also published this racial disparity in the NICU position statement that I found was really interesting to read. And then they came up with this infographic that looks at the 9 recommendations for equality of care. And many of these we have actually talked about throughout the talk this morning. And then this is the article I referenced from Advances in Neonatal Care on Becoming an Anti-Racist Neonatal Community. And this was published earlier this year. So I encourage you each to go and read that article. And then each of these websites or organizations have content that is dedicated or devoted to achieving health equity and reducing health disparities. So I mentioned NAN, and I have the reference there, as well as the California Perinatal Quality Care Collaborative has a lot of initiatives around disparities in NICU care. And some of those articles that I referenced earlier or reviewed earlier can be found there. And then the March of Dimes, we talked about the Stigma Beyond Labels initiative, but they also have content on their website specific to reducing health disparities as well. And then the Healthy People 2030, the Centers for Disease Prevention and Control, as well as the Robert Wood Johnson Foundation. So we'll end here with the next steps. And I hope that each of you can identify that one thing that you'll take away from our talk this morning and start working on tomorrow that will help us to improve disparities within our units. And develop within your QI initiatives a health equity metric. And maybe you'll just start with one of your quality improvement projects and identify one process measure or outcome measure that you can stratify by either language or race and ethnicity. Because once we can identify where those specific gaps occur, we can focus on strategic interventions to reduce those disparities. And then finally, we need further research to focus on how these social determinants of health and race and ethnicity are potential drivers for preterm delivery, birth complications and outcomes, and how we can work to identify interventions to minimize and eliminate those. Together, we can all make a difference. And we will open it up for questions now.
Thank you, Rachelle, so much. And it's my pleasure to also introduce Natalie Hunt, who's joined us, and another member of our planning committee. And I'm just going to let the two of you, I know, Natalie, you have a few remarks and comments to add, and then we'll definitely open it up for some Q&A time. But thanks, Natalie, for taking time to be with us.
Yeah, thank you guys, Rachelle. That's a great presentation. So I just wanted to kind of add perspective as a Black woman, not only working in healthcare, but just also a Black woman that receives healthcare. I get both sides of it and trying to juggle both of those things. And I think a big part of that is understanding the history behind how African Americans were treated in healthcare and all the negative things that have happened to African Americans throughout the healthcare system, how that impacts the way Black people perceive healthcare now. And I think it's one of the biggest things that people can do is just understand that historic piece to it so that they have a better understanding of how to provide care to anyone of different backgrounds. It's hard. I work in the middle of Baltimore, Maryland. I understand the population that we care for, but I feel like if you don't come from that background and don't educate yourself on that background, it's hard to provide the care that patient population needs. And you're doing them a disservice by not understanding where they come from. You can't expect them to have the same resources, the same understanding. You can't educate them the same way that you would a different population. So I think it's obviously a very important overdue conversation that people need to have in their NICUs. And it's the downside is that it's taken so long and so many negative in your face things for it to become something that's being talked about, being really researched, being brought to the surface, but it is being brought to the surface. It is being researched and it is being talked about. There is progress in that aspect.
Rachelle, do you have anything you want to add to that or any other comments?
No, I think Natalie obviously makes a lot of really important points because me as myself, I don't have the shared experience and all I have is my ability to make myself aware. And like she said, to really understand that history and how it impacts maybe the trust in healthcare, access to healthcare, or that trust that doesn't exist, and how we can reach our patients where they're at and really try to understand and address those various issues. I think the awareness is really the first step of where we all can start to make a difference, because we need to just do our own research and make ourselves aware, help educate our peers that we work with. I think those are all really important pieces.
Natalie, do you have any specific websites or places where you recommend for people to learn more about some of the historic perspectives on maybe some of the research things? I'm thinking like Tuskegee and things that maybe some people aren't even aware of. Do you have any good resources, books, things that you've found helpful to open that conversation and educate others?
I think the resources Rachelle shared were very helpful, definitely a great start. I don't have any specific resources, but honestly, I think the first step is just going to Google and just typing the history of Blacks in the healthcare system. And there's just so much out there. There's so many different pieces. I'm still learning about the history. There's just so much, and it's out there. I think the first step is just wanting to educate yourself.
Yeah, 100%. In either of your units, have you started to have group conversations about race and the disparities?
Oh, go ahead, Natalie. Were you going to say something?
I was going to say, I think the George Floyd incident kind of was the straw that broke the camel's back. I think from that, our entire hospital has developed like a diversity and inclusion council, and every unit has committees, and now it's a more active thing. And so as part of that committee in our NICU, we've worked on just staff education. We have a bulletin board that we put education on, and I can tell you it is not welcomed as well as you would think it would be. It's just trying to educate people, and not in all, but we have gotten not so nice remarks. Why is this a thing for Black History Month? Why do we need to specifically thank Black nurses? Why do we need to point out certain things? And even hospital-wide, I've been told that from a higher managerial kind of perspective, it's not taken very openly as you might expect it to be. So there's definitely still a lot of work that needs to be done.
So I guess in using that paradigm that you shared, Rachelle, with that fear zone, that sounds like that there are still obviously lots of work to be done, and that there are still many people, unfortunately, in that zone of just, this doesn't exist, this doesn't help things, focusing on these kinds of history doesn't make it better. And I think, not that we can solve it today, but at least knowing, that they're in that zone and they're just not even self-aware really yet, or they're still in denial even, that's where they are. How about you, Rachelle? Are you guys seeing?
Yeah, I think Sharp Healthcare also has, as a whole system, hospital system, has really addressed this in having safe speak conversations where people can come and have an open forum for discussion and learn about different cultures. It's now at the entity levels where they're developing the entity related diversity, inclusion, and equity task forces. And I think there's still a lot more work we can do at the individual unit levels. But I think one of the places where we've started specific in our unit is really looking at our quality improvement projects and stratifying by race and ethnicity, because for some people you need something that's objective and you need to show that these disparities do exist. And then you can start having more conversation and dialogue around that when you have something that's very objective. But I think, to what Natalie said, I think people are all at various different stages of this, and it makes having that safe dialogue a real challenge, because people get it's a sensitive topic for a lot of people, and it causes potentially division. And I wish that wasn't the case. But I think it does make this just more of a challenge to find those safe places to have that dialogue and those conversations, because everybody is at different places. And it is a journey. It's not going to happen overnight. But I think the more that we can just share that awareness, educate people, and then look at how we can objectively measure the own disparities we see in our units, will help to move the target.
Yeah. Natalie, do you find that your families respond, or do you think that families in the NICU respond better to same race providers, even having at least one other, say if it's a Black family and that there's at least one other Black nurse or Black provider, does that help? Do they gravitate towards you? How can we embrace that and maybe acknowledge that? Or is it more just as us, as say a different race person, just saying, do you feel comfortable with me today? I'm just asking, like, what's the dialogue we can have? And does that help?
I'm honestly not sure, because I don't have the other perspective of a Black mother interacting personally with a white nurse or provider. And it's all individual as well. Some people, it doesn't really matter. They're just going to be a difficult person but I do feel like, just having my perspective as someone that seeks healthcare and work in healthcare, I feel a little guarded when I am caring for a Black family because I know they might not be getting as much as a counterpart family. And I'm always, and I guess that's also my bias as well, right? I'm already on guard knowing that, oh, this is a Black family. How is he being treated versus this other family? We did this for this family down the hall. So why are the babies are in the same space, in the same progress? Why are we doing a different thing for this baby? That's my own bias as well. And I know that I go into those situations, I feel like maybe trying to overcompensate, maybe to make that mom feel like she's being heard, she's a part of the care. She and her baby are important to this NICU. So it's hard. I don't know the other part of how I've never obviously not really asked a parent those kind of things, but so I'm not sure, but I know I do have my own bias that affects the way that I function in the NICU too.
I think it's biased, but I also think it's real. So that's a difficult place to be. But I love that hierarchy of needs that you shared, and just showing that when someone is having to overcome race or other disparities, they do sometimes need that additional just check in to make sure that it's like you were showing in the bicycle, right? It's not equality, it's equity. And that it's that doing more for a family who has more needs or comes from a baseline of deficit to start. I feel it's almost necessary. And almost, again, it's that trying to go back to that equality piece of, okay, every family should only get one voucher. There could be a white family or a Black family that needs 4 vouchers today, right? And that's the equity piece, not the equality piece. And I thought that those were really helpful in even helping, like you, Natalie, say, okay, I'm actually not giving more. I'm giving what's needed because I know that this family is already coming from a place of needing more support or needing more communication or needing trust, and me at least addressing that. Do you feel safe? And also I'm thinking of the one conference, right? Of like, why me? Why this? Why now? And each of us own that piece of the daily practice. And you, Natalie, or you, Rachelle, it's like, it's why me? Like, why me, the white girl with this family today? But why me? What can I offer? Can I help to heal some of that past by my example and by what I do today? Can I help to heal that and to show that equity? Or you, Natalie, like, why me? This family needed to have someone that looked like them, that made them feel more safe. Like, why me? So I think each of us can insert ourselves into that moment and just say, I'm here for this special moment, maybe to give trust, to give healing, to be that bridge, to be an example. And to just, I guess those are those incremental daily things we can maybe do.
I think one of the biggest things that is a pet peeve that I hear, and I'm sure everyone says it probably in every NICU, is when you get that preemie baby and it's okay, it's a Black little girl. She's obviously going to do well. Or, oh, it's just a wimpy white boy.
Yeah.
So just that right off the bat, you can already see how your plan of care is probably going to go different. Are you going to give that little Black girl more CPAP, or are you just going to let her sit on like a cannula because she's a little Black girl and she'll probably do better? Whereas the little white boy, you're just going to put them on CPAP because you already know they're not going to do well. So it's already that from the very beginning, you're already having separate treatment plans that are based on gender and race instead of what is their clinical needs.
That's a really good example.
Yeah, that's a great example of the existing language and narratives that are in our units, because we've all heard that. We've probably used it ourselves, or I have. So yeah, I think that's a great example of that. Awesome. And I think when it comes back to, I think there is literature out there that really supports that you should have more of a diverse workforce that reflects the demographics of what you care for in your unit. But there's multiple barriers and layers that affect how we can get to that diversity in our workforce. And I think when you look at access to education and what levels of education different people can achieve, whether it's an ADN, a BSN, or an MSN, speaking with nursing, there is structural barriers that hinder what level of education. And then when we look at magnet hospitals who seek for a BSN or higher, it almost just is counterintuitive to trying to create that diverse workforce So I think that's outside of specific to the NICU. I think that starts even downstream on how we can address that and get equal access to higher levels of education.
Yeah, yeah. And that was what last month when we had Dr. Frederick with us, that friend of mine from Tampa, who's created the Education Academy down in Tampa, where they are starting to reach out into the middle schools to help underserved populations to get connected into the medical profession. And they've had 31 physicians now graduate from that program.
Awesome.
And they started as junior high kids and went through the academy as just a high school program where they got to shadow. And then even the organization we talked about last time helps with even college application fees, because that can be a barrier, right? You have to apply to 20 places and the family can do that. And as someone's mentioning, last month, we had also some of the, oh my gosh, my brain right now. We had our speaker from Glow Preemies, Ashley, and she was sharing some of the programs that they're doing for their families from 18 up to 18. But does anybody want me to unmute you? Do you have a question or a comment? Just raise your hand and we can either bring you on camera or at least unmute your mic. But thanks to all of you for being here and for this conversation. Happy to leave time for any of you who want to add in what are your units doing, put it in the chat. I love some of this, Ruth, that you're mentioning. All of us are doing QI projects. And I feel like, Rachelle, that's a really great suggestion. Just start adding that extra dimension to our projects. That's fantastic.
So I mentioned the early skin. Oh, go ahead, Natalie.
No, go ahead. Sorry.
I mentioned the early skin to skin initiative, but we're also looking at stratifying some of our processes and outcomes around primary care nursing or continuity of nursing, because we've shown that, and science has shown that continuity of nursing and reducing the number of caregivers improves outcomes in infants in the NICU. But do we provide that continuity of nursing across all race and ethnicities? And so we're looking at stratifying that. And we're also looking at stratifying race and ethnicity and looking at the amount of breast milk or some breast milk at discharge, which is one of the metrics that we report for CPQCC here in California.
Hi, Rachel, it's Ruth. Can you hear me?
Yeah.
Okay, first of all, I just wanted to thank you guys so much for opening these discussions, and I've learned so much. I've joined the past 2 times. I was wondering some of the things that we're working on that I was thinking that we can add these metrics to are, like, we rolled out a SENSE program, which is like a program to help improve the neurological outcomes of the babies less than 32 weeks. And when I'm doing my leadership rounds, sometimes I ask the families, have the nurses been educating you regarding this? And are you participating in this? And I noticed that we do have some disparities also having to do with age. The younger moms maybe not being given as much information, and as well as ethnicity. And so I'm really curious to see how that goes. I'll be discussing this with the teams, and also primary care nursing, which families are getting the primary care teams and which ones are not. I'd be very interested to share that information with our teams as well. Have started an equity, inclusion, and diversity committee in our unit, and we'll be having our first open forum to discuss microaggressions, where one of the staff nurses are going to share her story, and we're going to do a little bit of education for the staff, and then to open a safe space for people to share. And so I'm really excited with this work, and I'm really excited to continue learning from all of you. Thank you so much.
Thank you, Ruth. And you work, I know, in a very diverse population area, lots of opportunity to lead out in that area. So thanks. We'll look forward to hearing back from you how it's going and sharing what you've learned and any new things we can all do. Anybody else? Just raise your hand. Happy to unmute you or put your comments in the chat. But thank you both, Rachelle and Natalie, for just taking time and being here with us and just helping us to just continue to get comfortable with uncomfortable. And to just be that first person. I loved at the end, of course, you said, find that one thing, right? And just to find some way that you can move your own needle through those phases from fear to growth. And I think that's just our own personal journey. And easier for some than others. And we just have to be, like you said, patient with everyone where they are, but continue to push the conversation forward. Anything else, ladies, that you'd like to add, or anybody else want to raise their hand? I'm happy to unmute you and have you join the conversation.
If not, I just wanted to share, if I just like to read a perspective from just a commentary that was published a few months ago. It's just a commentary it's called Perspectives on Race and Medicine in the NICU. And they just got the perspective of a med student, a neonatologist, and a parent in the NICU. And I just thought the mom's perspective was not eye-opening, but like, I feel you. The things I just wanted to share, she just starts off and just says how thankful she is for everything that they've done. They were amazing, the staff in the NICU. But it goes on to say, but I knew that it's human nature to help people who you like. So every day I entered the ward and I did my best to be likable. I needed the nearly all white staff to know I was smart and friendly and gracious and involved. I needed them to know I was educated, I was employed, I was married. So badly did I crave their help, I consciously played the role of respectable Black woman. And I played to win. I remember feeling that I had to be strong so that they would know I was capable, but not so strong as to come off as angry. I didn't want to seem overly emotional for fear that kind of expression would loom too large and overshadow, in their eyes, my intelligence and capability of processing information about my children's health and well-being. So I saved my tears for my husband at home and sobbed in the car in the hospital parking lot. I later learned that I was not alone in my worries. My aunt shared with me that when her son was born with a genetic disorder, a NICU nurse who was a woman of color pulled her aside and gave her 2 pieces of advice. The first bit was crucial. Your baby will need all your strength, she told her. Whatever you have in you, you bring it. The second bit of advice, however, was this. Don't let them see you cry. You can cry with me, but don't let them see you cry. The them in that sentence was clear to my aunt and to me when she recounted the story, the white doctors and nurses. And I think that perspective, I take that perspective and I place that on every Black mom that I encounter in the NICU, because I know that perspective. I take that perspective when I go to see my healthcare professionals. And so that's the perspective that I see from them, or I get from them, that makes me want to make sure that I'm doing everything that I can to make sure they're getting the best care that they can get and that they feel that they are being cared for, their baby is being cared for, because that is just the life of being Black in the healthcare system. You feel like you can't trust, you don't know who you can trust, you don't know what to do if you don't trust, you don't know the top person in the NICU is probably another white person. And so I just wanted to share that perspective, and I just hope that it gives you something to think about, if nothing else. And I can share that reference as well.
Thank you so much. We're getting some chats about that. Yeah, so if you can provide that, I think people would like to be able to reflect on that more later. You choked me up with that.
Sorry, it chokes me up because that's when I go see my doctor, I'm picky, and Rachelle was saying it's the numbers of these risks. It's not even including, it's not just the poor Black people, it's the highly educated, middle income Black people as well. And I have 3 babies every time I went in. Am I getting the best care? Are you listening to me? I don't feel like you're listening to me. And I'm educated, I know things, and I still have that. Am I getting the best care? Is this the same care that you would give someone else? That speaks to me. And again, my bias, that's why I do put a little extra something into when I'm giving care to that Black family, because I know there's a good chance that they're not getting everything that they need from my counterparts, which I feel like is not fair. And I feel absolutely bad for thinking that, but I also think that's a part of the reality as well.
Yeah. When you hear that emotion, that additional emotional burden that we have unintendedly, is that even a word? Unintended to give to other families, and that there have been biases in the past, but that it's just heartbreaking to think On top of having a baby in the NICU, you as the Black woman and Black mother feel like you have to play a role just to get your mama bear needs met, to fight for your baby, but to not be too aggressive. I think that it just characterizes it perfectly. Why should anyone have to feel like they have to play a game to get the best care for their baby?
It's like you can't even just go to the NICU and think about your baby and care for your baby. You have to spend so much time and energy trying to put off a certain acceptable persona. And then you leave at the end of the day and you're just like, I didn't even interact. I didn't even have those moments with my baby because I was too busy trying to be this other person for everyone else. And
it's an unfair burden.
Yeah, thank you for sharing that.
Oh, I don't know that we should have anything more than that. I feel like just keep staying with this emotion is important and just reflecting. So thank you to both of you for helping us to be comfortable with uncomfortable. Let's all just put in the chat some many thanks to these ladies. Maybe all of you are like me and you're getting your tissues and wiping your eyes. Your hands are busy and you can't type right now. But no, thank you, Natalie, so much.
Yeah, I put that article in there, and there's also the perspective of a white neonatologist. There's a perspective of a medical student, and even neonatologists saying how, she had this great relationship with a Black mom, and then the baby got sick and all of a sudden it changed and she didn't get it until after she educated herself and had an understanding of the history behind it. And it's just imagine how much better the care may have been if you already had that education. It's so many things, it's so much. And like I said, I'm still learning about it and learning about my own biases and just everything. It's so much, but at the end of the day, you just want to be able to give the best care to every single patient and family that you encounter. And just like if you were to decide to go to a Native Indian reservation and care for that population, you need to know about them. You need to know about who you care for so that you can give them the best care. And that's really what parents and patients want.
Yeah, thank you so much. Thanks for all of you for staying on. And yeah, Jackie, you bring up language barriers. Yeah, that's really real.
It's a big deal.
That's like another conversation.
That's a whole QI project. And it's just oh gosh, I have to go get the translator iPad to go talk to that mom. I don't have time for that. Yeah. But I can go talk to this mom because she's in the room and we speak the same language. There's so much.
There's so much to do. And yeah, I think it's maybe in some units, starting with language is an easier start, right? Again, just starting somewhere and maybe just even equalizing that. Like you said, how do we make it even easier for providers to grab that translator? How do we advocate for more in-person medical translators on night shift and not always relying on the digital piece? So yeah, I think those are also important. And again, like you said, Rachelle, just starting somewhere. I know we were talking at Stanford, I think at the last steering committee I was on with them, just about every first hold having a medical translator, even if you feel like the family gets what you're doing. And I thought they can now track whether or not that's happening, and that's a place to start.
Yeah, we just had that conversation last week with our early skin to skin task force. And when we looked at that disparity between English speaking and Spanish speaking, and the huge disparity we saw between Hispanic mothers and fathers compared to all other race and ethnicity. And that's what we said for that first hold. If they're not English speaking, we need to grab that translator or that translator iPad and have it there that families really understand so we can make it successful.
Yeah, really good. Thank you, ladies, so much for today. And hopefully it's just, again, part of the beginnings of the conversation. And as we all are learning more and doing new things and have data to share, I think it's important to keep continuing to have these conversations. Thanks, Amanda. Thanks, Jackie and Ruth and everybody else who's chimed in here and joined us today. Thanks, Jackie, for that collective hug to all of us, and looking forward to seeing so many of you online and part of our conversations as the months continue. So thanks again, ladies.
Thank you, guys.
Bye.
Thanks, Kathy. Thanks, Rachelle.
Okay.
Yeah, thank you.
Bye.
Bye.
Hey, everybody. Thanks for staying all the way to the end and just journeying with us all through that emotional presentation and helping us to each find our way through this difficult conversation. through the emotions that come up, the thoughts, the biases, the unintentional biases, the unknown biases, all the things that Natalie and Rachelle really so eloquently shared with us. So thank you for being here. If you'd like to get some of the resources that they've mentioned, go ahead and click the link in the show notes or on the QR code. If you're watching this on a computer, you can scan that with your phone and go right to those resources. And those are the resources for the entire month of July. So we're just going to keep stacking them all together. So you just need to sign up once and you'll be able to have access to those week after week. So anyways, I hope you have a great week and I'll see you next time. Bye.